Lovely people. Happy Wednesday. I don't get to say that very often. I usually have to remind myself it's a Thursday or Friday when I get to hang out with you all, but I'm very excited for today. We are doing something unusual, which is I get to present a case finally on VMR. I haven't done that since the original version of VMR case number one. And I'm doing it today to celebrate our beloved case discussant, who I'll introduce in a moment. But first, let me hand the mic to the people who are making this happen logistically. First, all the way over to Russia. Lyra, do you want to say hi and update people on what you're up to?
Yeah, hi everyone, my name is Lyra. And yeah, today I signed my documents to the residency, so hopefully gonna be a resident soon. I will know more tomorrow.
Oh, wow. That quick a turnaround, huh? You submit the documents today, you know more tomorrow?
Yeah.
Wow. I don't know of any such thing equivalent in my universe. Congrats. I'm very excited for you. Definitely let us know tomorrow, okay? Amazing. Anmol, do you have any such news?
Um, not really just now. But congratulations to Lyra, and that's a wonderful start to the VMR. But I am currently in Texas for my second rotation and will
Yep.
be giving my step three very soon, and then I will be applying to residency, but it will take 6 months, so let's see how everything goes.
What have you done for fun today so far? Anything that you've enjoyed?
Well, I just came back from the rotation for
Oh,
fun.
no.
I did biostatistics over the weekend.
Oh my gosh. Wow. That sounds like so much fun. I can't wait for you to do it again. Yay. I promise we'll have a lot more fun over the next 57 minutes because we have the legendary Dr. Dan Restrepo with us. And those of you who don't know, I think Dan is a legendary hospitalist over at Mass General and has been doing incredible things in clinical reasoning from a very long time ago. In fact, he was actually the first, actually no, the second ever guest on CP Solvers. Period. So the first person we had join us as an external guest to the core group of podcasts is still somebody you know if you join VMR regularly is Dr. Stephanie Sherman, who did a syncope episode with us. Dan was an outstanding resident at the time and joined us for our first ever intrarenal AKI episode many moons ago.
What was
Um,
that, 2018,
I think
2019?
so.
It was
2018
somewhere
was,
around that.
yeah, pre-pandemic, right?
It was my chief year. Yeah, it was
Oh,
2018 or 2019, one of the two.
crazy. And here you are.
Yeah.
And it's such a treat. I'm very excited to dance with you today and present a case to you and really essentially learn from the wisdom you've accumulated since that very episode, which is terrifying, knowing how incredible you were then and can only imagine what have happened since. So I'd love to pass the mic to you to get an update on how life is treating you, how's work going, and then we'll jump into the medicine.
Love it. Just always so happy to be back here, but this is special to get to go back and forth with somebody I hold in such high esteem. Gonna have to get you, I mean, if not in person, then virtually to Boston to solve a CPC on the for the journal. So you're on my short list, Robbie, just so you know, and good to see familiar faces and some new faces. But been going good. Just came off service, kind of catching up with my life today, and excited to talk through a case. And hopefully you guys are going to be nice to me. I This is variable in the. I mean, there's always warmth and kindness,
Yeah.
but not niceness with the cases. So those are different things. Um, so I'm excited.
We're gonna have a great time. I guarantee that. I will make sure that you will be awake the whole time and not put you to sleep like your two doggies and mine here. And I think everybody else will really enjoy this ride. So this is a real life story. So there are cases from residency, Dan, that I've just framed and haven't let out of their frame because they were so special to me. So I've decided to unwrap a gift and share it with you all today.
Open the vault, take
Yes,
something out
open
of the
the
cellar.
vault.
Yeah,
Yeah,
yeah.
exactly right. So I'll tell you that I got a page from the ER that essentially said admission for hemoptysis. And in the modern era, that probably wouldn't happen in the way it did, but that's really what happened. Is I got a little text page. It says admission for hemoptysis, callback number blank. And so I'm curious, with those words landing on your mind, what are your stream of consciousness thoughts? Take it away.
So first impressions, I think lots of people are going to jump onto kind of the clinical acuity of like, how much is it? And I can never remember what massive is. Like, is it a teaspoon? Is it a tablespoon? So my brain tries to solve where it's coming from first, and that I kind of go from there. And with hemoptysis, I kind of like try to take an anatomic approach to it before we quantify like how dangerous and life-threatening it is. And so I think of anything from the tip of the nose all the way down to the alveolus, with two kind of red herrings, if you will, one being truly epistaxis that folks are coughing up, or the other is that, actual hematemesis that folks are throwing up. None of them are good, but it's kind of important to codify which of the three we're talking about: hemoptysis, epistaxis, or hematemesis. Now, assuming it's true hemoptysis. Obviously anything from the upper airway. I think epidemiologically, we think of bronchitis probably as the most common cause of hemoptysis, typically like a streaky at the end of a vigorous kind of viral syndrome cough. True pneumonia, obviously a little bit further down in the lower respiratory tract. Pulmonary malignancies, sort of bronchial or endobronchial lesions, can cause that. But then we can think about kind of alveolar syndromes in the way of alveolar hemorrhage because of capillaritis, or because of bland hemorrhage in the setting of coagulopathy, or kind of pulmonary AVMs, or anything that will lead to bleeding from the pulmonary circulation or the bronchial arterial circulation. So those are kind of like my quick ways of thinking through hemoptysis. Obviously, the host is going to matter a ton, as it always does. We think about the enabling conditions, but I usually kind of run an anatomic list from kind of the tip of the nose all the way down to the alveolus.
That's absolutely superb. I love that. I'm curious just to inventory your experience as a hospitalist, because I practice in the ER so much that my denominator for hemoptysis is diluted by the benign nature of the sort of benign outcome that the vast majority of patients have. Say if you were to query your experience as a hospitalist, what are the things that you've seen actually make it to your realm for hemoptysis?
That's a great point. I think the base rate of badness truly goes up once you make it in. The other thing about hemoptysis, it's just one of those concerns that you can't really discount, even if it's not happening actively in front of you. It just is one of those things that if you can't figure out, it's one of those benign things, usually ends up getting admitted, because we can't really discount a whole host of really bad things. So what do I end up seeing a lot of? I probably most commonly will see probably lower respiratory tract infections in the setting of folks who are, let's say, anticoagulated or coagulopathic. We'll see vasculitis a decent amount, and we'll also see pulmonary malignancy, I think, pretty well represented in kind of causes of hemoptysis.
I love that. Thank you so much for sharing that. So what happens in real life for resident students and anybody on the hospital medicine side is, I think some people are more and more inclined to take a look at the chart before they give the call back, and that's certainly the kind of resident I was. I'm a little bit more different now, and I like to run to the patient and talk to the patient first before I talk to anybody else, which logistically is hard in some places. So I pull up the chart and I see the first sort of like few things that I learn about this person is he's a 46-year-old man at the time that I'm seeing him. And I'm trying to be clear about the timestamp because I saw quickly a discharge summary from 5 years ago. And so let me share with you what I see from that discharge summary 5 years ago to give you context for this person. He was admitted for hemoptysis at that time, and the hemoptysis seemed to be decent in severity given the fact that he was admitted. They got an X-ray and a CT scan that showed some bleeding in his lungs. It didn't specify where. He had essentially some X-ray and CT abnormalities, but he had no obvious bleeder vessel, no pulmonary embolism, no aortic disease, no cavitary lesion, no large mass. Essentially, just some ground glass opacities. He was admitted for a couple days. The hemoptysis stopped by itself. He got some supportive treatment with inhaled tranexamic acid, and he was discharged. He has no other notes in the healthcare system. And I look at his med list and I see he's not on a blood thinner. So let me stop there, and I'm curious what happens to your mind with this context now.
I think I always worry about those discharge summaries that I have also written, and I'm sure you've also written, Ravi, of like, well, we don't know what did it, but it stopped. And like a lot of bad stuff was kind of discarded. And so then you're left sort of syndromically to hope that this never happens again. Or you need time, and diagnoses take time. And so now we have a recurrent sort of phenomenon that happens 5 years later, or maybe it's happened in the interval time and we just haven't captured it with our in our kind of charting system. And so important to kind of figure out if there have been any kind of more bouts of this in the intercritical period. But there's a few things that I would have wanted to see at least at that time. We see mention of ground glass. We see no endobronchial lesion. We see no pulmonary vascular problems. But this doesn't kind of sort of take, and we see no anticoagulants or antiplatelets, I'm assuming, and no overt coagulopathy at that time. And so I'm assuming that still like leaves us with either kind of a proximal lesion that we didn't see because he didn't undergo bronchoscopy, or an alveolar lesion that we have kind of yet to really discard. And one test that like I will frequently bring up in these discussions, but I will frequently ask of my teams, and I will frequently get myself, is a urinalysis. And I think I think it's called a urinalysis because you actually have to analyze it. And I promise to all of the listeners on it is useful for things other than misdiagnosing urinary tract infections. And so I think any kind of hematuria or proteinuria at that time would have really kind of jumped out at me as a signal for something more systemic causing kind of recurrent hemoptysis. Obviously, we're going to probably get some more information on this go around, but that would have been one thing that my eyes kind of went to look for in terms of looking for systemic causes and alveolar causes of hemoptysis. And obviously, I think we'll learn a little bit more about his epidemiology in terms of smoking or other risk factors for malignancy, in terms of where we would prioritize a bronchoscopy in terms of completing this evaluation.
Absolutely superb. There's so many things there that I think a lot of people will write into their notebooks or even maybe look up. But one thing I wanted to zoom in on with you is you said something so powerful from a clinical reasoning perspective is you are actively looking for distant organ involvement in hemoptysis. And I think it's true that whenever we're trying to figure out a problem, we'll let the patient guide us to other concerns or complaints they have. So say somebody comes into hemoptysis and says, hey, my right leg is swollen, you're going to pay attention to that. But you're teaching us to actively look, even without any clues from the patient, at renal involvement. And I'm curious, is there any other, I'm thinking out loud with you honestly as we do this, are there any other organs that you actively try to look for, even absent any clues handed to you from the patient? Just like you did
That's
with
a great question. I think on exam, like when we're seeing the patient,
yeah.
not like doing a chart biopsy, I think looking at joints, looking for rashes, looking for Raynaud's, looking for kind of the nail bed exam, looking for ulcers elsewhere in the mouth or in the nose. So those are things that I think it's somewhat one of the big things that we need to do at the bedside, or when we're reading an electrocardiogram or a chest X-ray or looking through a chart, is like, what am I looking for, as opposed to what am I looking at? And that really kind of emphasizes the hypothetico-deductive model and puts us in a present and active frame of reference as we're kind of combing through clinical data.
Wow, y'all, he was this brilliant many years ago. I think it's unreal. Yeah, I love that line. It's so powerful. Uh, what am I looking for? Not what I'm looking at. Beautiful. Okay, so we go see the patient, and now this is not how I got signed off from the ER and so on. So, but this we go see the patient. Okay, so he's 46 and he says that he started vomiting blood 2 days ago. It's a decent amount. He says he's had to actually use a towel to wipe off the blood a couple of times. Um, and you see that, right, I'll just share an observation that in the room, there's a sputum cup that has like, gosh, a good 5 to 10 cc's of sputum already. So you're impressed. And actually, there's a couple of stains on his cheek too. He has no fevers, no cough, apart from just to the hemoptysis itself. without any, it has no cough that doesn't bring up anything but blood. He has no malaise, no weight loss, no shortness of breath. And this started abruptly 2 days ago without warning. At baseline, this is kind of filling out who he is. At baseline, he's exceptionally healthy, he has no problems, works a vigorous job that requires activity without any limitation whatsoever. So the story, the eloquent historian, the story that he paints is like he's robust, he's healthy. 2 days ago, this happens. And then I ask him, well, what happened to you 5 years ago? He's like the exact same thing. Just started out of the blue cough, bring up a lot of blood, came to the hospital and kind of shared. They watched me and was kind of a little disappointed. Like they didn't really, quote unquote, didn't do anything for me. And then he's never had this. He's had 2 episodes 5 years apart, no problems in the middle at all. And so officially, no known medical history, not on any meds, doesn't really follow with care. He's 46 and very healthy. So he really has not had health care in those 5 years. There's no relevant family history that he could outline. He does not smoke. He drinks socially 1 or 2 drinks per week. And then there's no relevant, just to make sure that this is HIPAA compliant, I'll say that there's no relevant social history. He's a very colorful human being with a really cool job. But for the purposes of simplicity, thankfully, none of those variables are actionable today. So I'll stop there and see what this does for you, Dan.
Well, it makes it harder, right? That now you have just this episodic, and so you mentioned the word vomit. Did he
Oh, did I
say
say that? I'm sorry. No
Yeah.
vomit. No vomit.
Okay, all right, cool. So this is like painless, episodic, brisk hemoptysis.
Perfect.
Is how I kind of frame it from a problem representation. And an otherwise like healthy guy that doesn't have good kind of epidemiologic risk factors for a lot of the things that we talked about, VTE, cancer, you wouldn't expect sort of alveolitis to kind of just happen in 2 days without people feeling like absolute crap beforehand, malaise, fatigue, or any other kind of constitutional symptoms. And so I wonder about like a brisk bleeding vascular lesion in terms of kind of an angioectasia. I'd want to know about kind of any prior nosebleeds or history of nose bleeding, or when we examine him, looking in his mouth in terms of any kind of sort of lesions or any petechiae or any kind of vascular lesions that we can see in the mouth. But, sometimes these sort of hidden, basically like a diverticular bleed of the lung, or like a Dulafoy kind of lesion of the lung, because this strikes me as something without kind of systemic antecedents that's just gushing for small periods of time that may be actually quite hard to find with our traditional kind of evaluation. So I don't really, this just makes it really hard. It doesn't really, there wasn't some thread I could chase down other than this poor guy without any relevant epi just has this happen to him, every once in a while, and it's pretty hard to diagnose and pretty significant.
Super. I'll let that discussion stand on its own. I think we'll come back to reflect on it later on. So his vitals are all normal, and his exam, you just hear some crackles in the right upper lobe
from blood. From
exactly.
Blood that he
And so I will give you his basic labs, which I'll keep very simple. Lyra, you have a simpler job today. And also, sorry, Dan, I should explicitly say to everybody that the only abnormality with a thorough exam is those crackles. So everything that you mentioned, including looking at his mouth, his hands, his joints, his heart, nothing. And then his labs are also completely normal, including a urinalysis. And then his X-ray, as you predicted, Dan, shows a consolidation in the right upper lobe. There's no mediastinal disease, no pleural disease, no bony disease. And so this is at the point where the admission was called. This is happening again. Does he even need more workup? Well, how do we work this up? What do we do? So I'll pass the mic to you to share your diagnostic thoughts. And I'm really curious, like if you were receiving this admission, how much you pushed the case forward.
Yeah. So I get one reflection that was taught to me by one of our interventional pulmonologists is the importance of, how, like, the guy's not anemic, right? So a couple thoughts come to mind. One is that you bleed whole blood, and so that this is happening right away. But probably the more important thought here is that folks with hemoptysis do not die from exsanguination. They die from asphyxiation. And so lots of times I'll hear people be like, well, they're not anemic. Or like, well, you can't hide that much blood in the respiratory tree without having significant impairment in gas exchange and in respiratory mechanics. And so just a quick point that, like, just because he's not anemic doesn't mean that this is not a crazy significant amount of blood. Robbie has already told us that there's blood on his mouth and there's blood in the room. So just, I think, a quick little reflection. The question about the only thing that's come up positive thus far is this spot in the right upper lobe. And, was he asleep when this happened? He aspirated some blood and he coughed up, and this is more proximal lesion. Or is there something in that right upper lobe that's actually bleeding, right? So is that consolidative lesion an actual malignancy that's grown enough in these 5 years that we can actually appreciate it radiographically? Was there an endobronchial lesion there before that we haven't seen? Or is this just bland blood that we're seeing there? I put a lot of stock to your question, Robbie. When people come back for something, that matters to me. And I chased that down a lot further, especially when there was no answer the first time. So I would 1000% push this guy. And if he wanted to leave, I would try to convince him to admit him, because I think that, there's other tests that we can do in this case, especially if we can catch him with active bleeding. I think an angiogram protocol of the chest, I don't think that this is a pulmonary embolism, so I don't know that I would program it as a pulmonary angiogram, but rather a true angiogram to catch kind of bleeding bronchial arterial lesions. And I think at this point in time, he's bought himself a bronchoscopy to go in and look. So I 1000% think he needs more cross-sectional imaging right now. I would probably protocol it in an angiogram protocol, and I would be calling our pulmonary colleagues to go in there and try to look as far into that right upper lobe as they can.
Amazing. That's so shrewd and so powerful. This is a knowledge gap for me, and I know that we don't protocol things, but I'm curious if you can expand on that pro you just shared about the PE protocol versus the angio protocol.
Yeah, so a pulmonary angiogram protocol is basically when we're looking for pulmonary embolism, and we sort of try to time contrast to light up the pulmonary arterial tree as opposed to the systemic kind of arterial tree. And so in theory, folks will put in an IV in the upper extremity, and then they have some protocol where they infuse it and they count some number of Mississippis that they know until the contrast is in the right side of the heart. And ideally, for a pulmonary angiogram protocol, you should have the RA, the RV, the PA, and the main PA and the pulmonary arteries with their segmental and subsegmental branches like lighting up. Yeah. And that's a good CTPE or CTPA, or some people call it a CTA of the chest with PE protocol. But that's what a pulmonary angiogram CT protocol is. If you count just a few more Mississippis, the contrast will actually move over into the left atrium, the left ventricle, the aorta, and now kind of the true systemic arterial branches. In which case, if there is a brisk, active bleeding bronchial artery kind of focus, it could be identified at least, or there could be kind of some signal that we could kind of go down that avenue, and perhaps later with kind of colleagues in radiology do a bronchial artery embolization or something like that. It'd be kind of like the non-invasive first step to getting a bronchial artery embolization, or at least angiogram from interventional radiology.
Beautiful, absolutely superb. You're in a Dan Restrepo VMR when you're already past the halfway mark of teaching points on the screen, and it's not even halfway mark of the session yet. So as you predicted, interventional radiology and pulmonology were called. Actually, to be honest with you, I was so overwhelmed I didn't know what to do. I called my attending right away, and she was like, "Hey, you got to get these people." And I still remember the fear of this condition, really prompted by the fact that I've never seen pure blood in a sputum pump before. Unfortunately for him, he continued to cough a decent amount, but actually then stabilized. And so he got a CT with angiogram protocol, and the CT essentially showed ground glass opacities in the right upper lobe without any focal lesion or evidence of active extravasation. So let me stop there, and then you're absolutely right that the next step is in fact a bronchoscopy. But I'm curious, and the bronchoscopists are now approaching this case with this knowledge in hand, and I'm curious how that tips your scale.
Um, it's unlikely to be a large bleeding mass kind of in those segmental areas. And so the bronchoscopists are going to say, well, we don't really see that much there. I don't know what we're going to find. There was no extrav, there was nothing there. But I don't know, again, the central question is this sort of just a purely vascular kind of phenomenon with just brisk bronchial arterial bleeding in that area from some malformation or some fistula or something, and or are those GGOs like some form of pneumonitis that's causing some amount of bleeding from that area? And this man has never had like prior pneumonias or prior lung surgeries or anything that would kind of cause abnormal vessels there that we know of, right?
Correct. Yeah.
So this was like de novo. This just happened to him.
Yep.
Yeah, I think the bronchoscopist will probably take a look around other places in the lungs, which could kind of lend some insight, but they're probably going to focus most of their attention up there if they think that his gas exchange is okay and they're not like super concerned that the guy's like briskly bleeding, because that could be dangerous to kind of put him under to do these things. So hopefully he's still kind of on room air and doing okay in between these bouts. The other issue is, if he's not actively bleeding and they go in there, they may not find anything actually going on. So it may be a non-diagnostic study.
So much wisdom there, and I just share with you how concerned I was. And gosh, if you only saw what I saw, and you probably have, some of you, I know Dan definitely has. He starts vomiting. I'm sorry, I keep saying vomiting. He starts coughing up blood like no other. So the rapid response was called for a large amount of hemoptysis. And
I'm going to
so
start asking for an endoscopy pretty
I
soon.
don't know. It's just going to show you how rarely we see massive hemoptysis. I see hemoptysis like every other day, but
Yeah.
this guy is nonstop coughing blood. So I walk into the room. There's like 5 or 6 people, and there's suction. And so I will hand the mic to you to kind of steer the ship here. But we're very, very worried about how much this person is coughing up, and I'm curious what you think you would want to do to try to stabilize the situation now.
And by the way, we have no medical levers to pull at this point in time, right? He's not coagulopathic. He's not thrombocytopenic. We don't have any medications to reverse anything. So we have just good old fashioned, I think. I think he's going to need an airway at this point in time for control, just because otherwise he's going to be in a world of pain. And I think we're probably just going to have to put that affected like side down, and then we're just going to have to try to get an airway on him as soon as possible, because he's going to need an invasive kind of management of this. And again, this is the point where I think we need to secure his airway. We need to stabilize him. We need to try to at least go in there if possible, but to have the interventional radiologists on backup to try to get a bronchial artery angiogram and hopefully an embolization of some bleeding source at this point in time.
Incredible. That's exactly what happens. He gets a rapid sequence intubation done. They put him immediately with the right side of the lung down. The idea being that if that's the source of the bleeding, then with that being down, the blood that's gushing out of there is less likely to pour into the other lobes, further impacting his oxygenation. And he gets taken to the ICU. And in the ICU, they do a bedside bronchoscopy. And good for him is they visualize no airway abnormalities in any of the other segments, but they do see a large amount of blood coming out of the right upper lobe. They don't see any obvious endobronchial lesion, but they describe the fact that it was a bloody mess in there that they aren't 100% sure. And so, as you predict, Dan, he's immediately taken to interventional radiology, where invasive angiogram is done and a bronchial artery in the right upper lobe is visualized to be bleeding, and that is embolized. And so let me stop there and then see what your thoughts are now.
The classic scenario where this happens is bronchiectasis, right? You have sort of distorted bronchial architecture, and you have brisk bleeding from those ectatic airways into those ectatic airways. We saw none of this on the CT in the last 5 years. And it's just very odd that this has happened in what is otherwise parenchymally a normal lung, that there's some, without sort of systemic coagulopathy, thrombocytopenia, any other medications, anything like that. So there may be just some congenital defect there that over time with age has, some AV fistula, some AVM, something to that degree that has kind of just hit a critical mass and has eroded. And now you have bronchial arterial bleeding, which is why it is so brisk and so difficult to control, as opposed to something like pulmonary arterial bleeding, where we're dealing with an order of magnitude less kind of less pressure than systemic circulation. Because this guy, whatever his blood pressure is what's going in every single beat per minute of his heart into his lungs, right? So he is bleeding at systemic arterial pressure with a bronchial artery source hemoptysis.
Beautiful. We're getting near the end. I'm curious to ask you, how often have you seen bronchial artery embolizations be successful? Do you invest a lot in that intervention, or are you? I mean, my N is one.
My N of bronchial
Yeah.
artery embos is probably total under 5. So I don't know that I have it's not like taking somebody for a sort of diverticular bleed embolization or anything like that, where I have a lot more experience with it. So kind of going back to that hemoptysis versus hemoptysis track record.
Yeah.
Hopefully if it's a single vessel that's bleeding, it has some temporizing measure, at least for us to stabilize the poor guy. But I worry that because you asked me that, it means that this thing's going to get unplugged and start up again, and he's going to need to go to the OR with the thoracic surgeons, that the diagnostic test will be kind of a lobectomy or something like that.
Well, you're both the case discussant and presenter now, my friend. It was absolutely he rebleeds. He rebleeds. He goes to the OR, and unfortunately has to get a right upper lobe lobectomy. And I will tell you that reveals the final diagnosis. So, what are your final thoughts?
I just don't. I want to. I'm wondering if we're missing anything systemic, but it doesn't sound like we are. So it looks like we're talking with some localized process. And I'd be lying to you all if I told you that I have an exact explanation for what's happened in that right upper lobe, other than the fact that I'm worried about some vascular malformation or vascular phenomenon that is just friable and connected to the systemic circulation. So I don't even have a diagnosis for you, other than like maybe AVM, maybe AV fistula, maybe something up there that is congenital, because I just don't have a reason for him to have something acquired. And it's pretty unsatisfying to say that, congenital things sometimes hit critical mass in adults and then just start acting up, but that does happen. I can't say that this is, granulomatosis with polyangiitis. I don't have a name for what I think this is, other than I'm worried about some errant vessel that's just opening up and causing and wreaking havoc in this poor man's chest.
And Dan, if you remember Alquat 2, you actually said the exact specific final diagnosis in Alquat 2. And based on what you're saying now, either there's a lot of humility happening, or analogous reasoning is such a powerful thing that you're borrowing from hematemesis, and you said the exact, like, down to the syllable.
Like a pulmonary doula lesion.
Yes. Have you ever heard of that before? Have you heard of pulmonary doula? Yeah.
No.
So that's exactly what he has. He has a pulmonary doulafoy. And so how they figured this out is they do the lobectomy. They see there's no endobronchial mass, and they see a submucosal artery is actually in the airway. And on histopath, they see that submucosal artery having been penetrated the airway. So I'll hand the mic to you. You haven't heard of the pulmonary version of this, but what can you teach us about the larger entity of a doulafoy lesion?
They're hard to catch. But yeah, it's a dilated submucosal vessel that sometimes decides to peek its head up and bleed like stink, and then it just goes under and it stops bleeding again. And it actually endoscopically is quite hard to see, and is just sort of, again, dilated, brisk vascular arterial bleeding, which is what this sounded like. I've never heard of a pulmonary doula lesion, so that's pretty cool.
Yeah, I have to tell you, I think that it's so much easier to diagnose things that you've heard of. And I think most diagnostic errors happen in situations where the final diagnosis, but for many factors, which I think are very well described, you don't get there. I used to say all the time that you cannot diagnose a condition you haven't heard of. But I think you've proven that to be completely incorrect, because you just outlined the fact that you haven't heard of pulmonary doulafoy lesions. But the power of clinical reasoning isn't showcasing to people your logical thinking to a very elegant solution. I think the power of clinical reasoning is best demonstrated when you take a massive leap to an entity that you've never really heard of or described of from a very familiar place. And I think you having done that from literally just the HPI, when you were told of a gushing episodic vascular phenomenon, to draw an analogy between the GI system and the pulmonary system was magic. And for those of you who have now consumed this entire recording, I encourage you to go back to probably about minute 10 when you see what I think is the whole point of clinical reasoning demonstrated at its peak, which is to use a narrative to get to a conclusion, and let alone not even knowing that that conclusion may fundamentally exist, but to search for it. So I'll just share what I learned about pulmonary Dieulafoy from this case, and I had to do a little bit of reading because I haven't thought about it since then. But it is exceedingly rare. It is much, much, much less common than its GI counterparts, and represents the very rare phenomenon that a patient has a primary vascular cause of bleeding that isn't otherwise apparent in the pulmonary artery or the aorta or in the capillaries through capillaritis. So it's a very, very sneaky disease because it's primarily vascular. There's no associated parenchymal abnormalities. And most vascular abnormalities are picked up on the CT scan by seeing abnormalities in the pulmonary artery or the aorta, or as Dan said, by looking at the UA and diagnosing capillaritis. So it's incredibly sneaky. And not only is it sneaky radiographically, it's also sneaky clinically because, as Dan emphasized, it presents with periodic bursts of bleeding. It is classically described to be in middle-aged people with a little bit more male predominance, but I would encourage you not to upload that data definitively because the rarity of the condition mean that these descriptors are probably much more flexible than we realize. So thankfully, with actually his right upper lobe removal, he has had no recurrences. Most people only have one Dieulafoy, just like in the GI tract, so the risk of other lungs being involved is very, very low. And yeah, it took massive bleeding for him to get a diagnosis. I suspect that a small number of a larger number, but still rare, of these cases just never declare themselves in the way that he did, i.e., have no chance of a clear diagnostic path. So that's this case, a trip down memory lane from our 2 year for me, and I'm curious what your thoughts and reflections are, Dan.
Yeah, I think I yeah I was drawing kind of parallels. I think obviously, well, my brain started drawing parallels from a case that I saw more recently, which was a guy who'd had some horrific necrotizing pneumonia previously, got over the pneumonia, had parenchymal like scarring left over, and then had recurrent painless episodic hemoptysis. And so there was that kind of left me sort of in my brain, whether availability or not, it was these vascular malformations can just form either because of prior inflammation or scar or malignancy or radiation or whatever, and then just sort of have these brisk episodic bleeding. And so in my mind, since none of that was really pinging, this seemed like a congenital vascular malformation or AVM or whatever we want to call it, or arterial, and so that was sort of where I was left, but I was kind of relegated there by really truly being able to see that none of the other stuff was pinging, that like there was no other cause for this, and that we're left with probably just one vessel that's or a group of vessels that's acting up, that we just haven't been able to and employ enough resolution to really find it. And this poor man had to have a chunk of his lung cut out in order for folks to actually see it. So this is a case of, I think, very reasonable but very quick kind of escalations in the invasiveness of diagnostics, which sometimes I think are necessary to get to an answer, especially when somebody's this sick.
Absolutely superb, my friend. It was a real treat to hang out with you for these 40 minutes. I thought this case would go the whole hour, but I think that I left out a lot of the unnecessary noise, and your reasoning was so sharp and crisp. I was actually panicking a little bit at minute 10. I was like, oh my gosh, she's already guessed the DX. How are we going to get more juice out of this case? But I think that the learning was monumental, and maybe I can hand the mic to Anmol to take us through the journey of the teaching points.
Thank you very much for the great case. It was a masterclass on hemoptysis, something we see a little less. And I think it's important when we see a patient or a patient comes with us complaining of coughing out blood, it's important to differentiate if it is epistaxis or hematemesis. Epistaxis means bleeding from the nose, and hematemesis, that is coming from the GI tract. And all of this has different management and pathophysiology. So it's important to differentiate that. If we are considering it to be hemoptysis, then we will think about the anatomic approach starting from the tip of nose till the alveoli. So considering the lower respiratory tract, it could be something involving either the parenchyma or vascular. Things like alveolar hemorrhage, pneumonia, or pulmonary arteriovenous malformations can present like this. And Dr. Dan taught us that some of the common things which we might consider in the patients presenting with hemoptysis are lower respiratory tract infection, especially in the setting of coagulopathy or patients taking anticoagulants. Then vasculitis could also be a possibility, and along with that, lung malignancy. So whenever the patient comes with the hemoptysis, epistaxis, or hematemesis, it's important to quantify the bleed, also to understand the management perspective. And this patient had the recurrence of bleeding, the problem representation being painted as painless, episodic, brisk hemoptysis. So we thought that it's important to ask for the history of nosebleed or look for any vascular lesion in the mouth. Then we thought that alveolitis is lower down in our differential because it won't develop that briskly. And now, since the patient has presented with a recurrence of the same symptoms, we need to evaluate and formulate a diagnosis to actually help the patient. Then we discuss something called distant organ involvement. Classically, we're actually seeing the patient is having symptoms in the airways only, but it's important to see if the patient is having signs or symptoms in the other organs too, so that we can classify it to be systemic or localized. So it's important to go through review of systems. We can ask for rash, ulcers in the mouth, or any history of Raynaud's. And while evaluating labs and imaging, it's important to ask that what am I looking for rather than what am I looking at. And then that we also consider the significance of urinalysis. It is more than just UTIs. We diagnose more things with that. And if the hematuria and proteinuria are seen in the urinalysis too, we would consider there is a systemic cause of this hemoptysis. Then we saw that the labs were normal. So hemoptysis without anemia, it does not necessarily reflect that he is not losing out a lot of blood. So we need to be careful about that. And then we discussed a great point about CT angiogram protocol, pulmonary phase and systemic phase. So pulmonary phase is something where we want the right side of the heart and the pulmonary artery to light up with the contrast so that we can rule out pulmonary embolism and things or pathologies related to pulmonary artery. But with the systemic CT angiogram protocol, we just wait a few seconds for the contrast to go into the left side of the heart, and that the left side of the heart lights up, and then we can also visualize bronchial arteries in this case, and that will be essentially bronchial artery angiogram. So then we also discussed that the patient had massive hemoptysis after that. How would you manage that? We will assess ABC protocol and evaluate the need for endotracheal intubation and secure the airway. And then if we suspect there is something related to the bronchial artery, we will definitely get a bronchial artery angiogram and do the embolization if we see any bleeder there. And then we actually saw there was something related to the bronchial artery. So classic scenario in which that can occur is this bronchiectasis, but that would be surprising with a negative prior CT here. And we also thought about arteriovenous malformation and a congenital defect. And then we discussed that bronchial artery bleed is life-threatening and presents with hemoptysis. The bleeding is at systemic arterial pressure. And then we discussed ultimately about diulifoil lesion, which was the ultimate diagnosis for this patient. It essentially means a dilated submucosal vessel. It's classically seen in the stomach wall in the setting of gastrointestinal bleeding, and pulmonary diulifoil lesion is exceedingly rare. But it is a primary vascular abnormality, not an issue with the parenchyma, and it can present with periodic bleeding, just like the patient in this case. And possibly pulmonary diulifoy could be underdiagnosed rather than rare, but it's important to evaluate thoroughly about the hemoptysis. And I learned a lot from all of the discussion. Thank you very much.
Well, you clearly did. You got every single morsel of, if this were calories, I think you absorbed every single morsel of nutrition that Dan sent our way. That was absolutely super. Big round of applause for Anmol. A similar round of applause for Lyra, even though the scribing wasn't extensive. You look at the way she organized the whiteboard. The purple was for interventions. The red is highlighted for the key stuff. That was just Very, very outstanding job there. Thank you both so much. Final word to you, Dan. Sign us out.
Wow, it's just pulmonary doulaflow, just doula lesion. You learn something new every day. But yeah, I think comparative reasoning is important, and kind of I think a lot of it is just getting to identifying a syndrome and like comparing, and making sort of inferences based on that, and kind of painless episodic bleeding without any other kind of findings puts you in kind of a vascular fragility bucket. And if you follow that thread, ultimately we would have gotten to the answer. We just needed enough tissue to do it. So those are my reflections.
Super. Thanks everyone for an awesome gathering. See y'all next time. Bye.